Hello. Welcome to the Center for Connected Health Policy's Telehealth and Medicaid, a policy webinar series winter edition. This is our fourth and last webinar for this particular series. What's next? A roadmap for Medicaid telehealth policy beyond the pandemic. Next slide, please. My name is Mei Kwong. I'm the Executive Director at the Center for Connected Health Policy. Before we begin our webinar, a few disclaimers and friendly reminders. Please know that any information provided in today's talk is not to be considered legal advice. It is strictly for informational purposes. If you are looking for a formal legal opinion, please consult with legal counsel. Also, if there happens to be a product or a company mentioned, know that neither I nor CCHP has any type of relationship with such a company. Today's webinar is being recorded, and the slides and the recording will be available on CCHP's website approximately 48 hours after this webinar. We also ask that everyone please refrain from political statements or advertising commercial products or services during this webinar. Know that there is a Q&A function where you can enter in questions for our panelists today. The chat function should only be used for technical difficulties with Zooms or questions that you have regarding the usage of Zoom. Next slide, please. A little bit of information about CCHP. We were established in 2009 as a California Telehealth Policy Organization underneath the Public Health Institute. We became the federally designated National Telehealth Policy Resource Center through a grant from HRSA, and we've been serving in that capacity ever since. But we also work with a variety of other funders and partners on various projects related to telehealth and connected health. Next slide. We are a member of the National Consortium of Telehealth Resource Centers. There are 14 telehealth resource centers underneath the same program at HRSA. We all receive government funding to provide technical assistance on telehealth. There are 12 regional resource centers that cover specific states, and they help folks with questions around the program operational level, policy, and technology. If they have questions around policy and technology that they are unable to answer, they elevate it to the two national resource centers. CCHP is the one on policy, and there is one on technology based in Alaska. I encourage you to reach out to your TRC if you have questions regarding telehealth, but know that all 14 work very closely and collaboratively together. So I always like to say, if you reach out to one, you're really getting all 14 of us. Next slide, please. This is our CCHP team, which I have to thank for their help in putting this webinar series together. Special thank you goes out to Samuel Taylor, who organized the majority of the work for this. So thank you, Samuel. Next slide, please. So to let you know, this is the end of our winter series, but CCHP is planning a spring series. These are the dates that we have for that particular series. We also have a hashtag that we hope that you will use during this webinar. It's Medicaid Telehealth at CCHP. And also, if you have ideas for the spring series or speakers, or if you have a Medicaid program where you think you are doing some innovative work around telehealth policy, please let us know. That is the purpose of this particular webinar series, is to have Medicaid programs share with each other some of their innovative works and information, some of the challenges and solutions that they have come up with in dealing with telehealth in their Medicaid program. So we encourage you to reach out to CCHP if you have questions or if you have ideas, or if you have a speaker or policy that you think would be interesting to your fellow Medicaid programs that they would like to hear from in a future webinar series. Next slide, please. We are in for a treat today. We have a great lineup of panelists to talk about our topic. First up, we'll hear from Joanne G., who is with MACPAC, and then we will hear respectively from the Arizona, Colorado, and Oregon Medicaid programs. So we'll start off with our first presenter, who is Joanne G. Joanne is a congressional liaison and a principal analyst at MACPAC, focusing on children's health insurance program and children's coverage, telehealth, quality reporting, and Medicaid response to COVID-19. Prior to joining MACPAC, she was the program director of the National Academy for State Health Policy, where she focused on children's coverage issues. Joanne also has been a senior analyst at the Government Accountability Office, a program manager at the Lewin Group, and a legislative analyst in the Department of Health and Human Services, Office of Legislation. She has a master's of public health from the University of California, Los Angeles, and a Bachelor of Science in Human Development from the University of California, Davis. So I'll turn it now over to Joanne.
Great. Hi, everyone, and thanks, May, for the introduction and, of course, inviting me to the webinar today. I think this webinar series from CCHP has just been so important in really highlighting all of the advances in Medicaid and in telehealth over the last several months. Today I'm going to be just providing a pretty high level overview of Medicaid and telehealth, and hopefully that's going to help set some context for what we will be hearing from our state colleagues. Next slide, please. So today I'm going to just give a brief little overview of MACPAC for folks who are unfamiliar with MACPAC, and then really dig into telehealth and Medicaid, and really just sort of coming at it from a pre-COVID, during COVID, and post-COVID perspective. I have a few resources from MACPAC that I'll share with you, and then of course we'll have time for questions at the end. Next slide, please. All right, so for those of you on the webinar who are unfamiliar with MACPAC, let me just say a few words. And the first thing, of course, is to address this acronym. MACPAC is the Medicaid and CHIP Payment and Access Commission. We are a nonpartisan legislative branch agency charged with providing analysis and advice to Congress and HHS on a whole host of issues in Medicaid and CHIP policy. MACPAC has 17 commissioners, each are appointed by the Government Accountability Office or the GAO. And they really bring a breadth of experience and expertise in Medicaid. For example, we have commissioners who are former Medicaid directors, federal officials, health services researchers, health plan and health system representatives, and importantly, beneficiary advocates. I'll also just note that we have a commissioner who is the mom of 2 kids who get their coverage through Medicaid and CHIP, and she brings very important perspective to our meetings. We issue reports to Congress twice a year, March and June, and that's every year. They include our analyses and data and any recommendations that the commission might have made. We also provide technical assistance and a host of other publications and resources that are on our website and that are really meant for anybody in the policy community to use. Next slide, please. All right, so what can we say about telehealth and Medicaid in the pre-COVID time? Well, we know that nearly all states, not all, but nearly all states provided some sort of Medicaid coverage for telehealth, and that coverage really varied quite widely with respect to modalities covered, specialties, and payment policies. States had and continue to have really quite a lot of flexibility to design their coverage of telehealth. And of course, that flexibility is a very important aspect of the federal and state partnership in Medicaid. In addition to the Medicaid-specific policy decisions that states have to make when thinking about their telehealth coverage decisions, there are a number of considerations that are external to Medicaid, but that affect their Medicaid decisions. And those are things like connectivity, technology, licensure, privacy, and provider workflow. And so obviously those are things that would affect other payers as well. The March 2018 MACPAC report to Congress included a chapter on Medicaid and telehealth, and we note, the bullets that are on this slide. But we also noted that at the time, there was relatively little published data or research on telehealth in Medicaid specifically, and that includes on utilization, spending, and outcomes. I think it's safe to say that in the intervening years that has started to change. Next slide, please. All right, so we are in a time of COVID. And so what do we know about telehealth and Medicaid during this COVID period? Well, we know that there's been rapid and expansion of telehealth in all states. And now all states are covering some form of telehealth. The variation in those policies still exists, of course. But that's kind of the nature of Medicaid, I suppose. States in expanding their Medicaid coverage of telehealth during the public health emergency really leveraged existing Medicaid flexibilities. and authorities. So unlike Medicare, where there were numerous changes in federal authorities to permit the use of broader use of telehealth during the public health emergency, that really wasn't the case in Medicaid because of the amount of flexibility that was already in the program. One thing that was new, though, was that CMS issued telehealth guidance and toolkits to states. And I think this was really great because it was probably the first time that we had seen such information from CMS. Another thing that was really notable, I think, is that CMS issued a Medicaid and CHIP preliminary data snapshot that included data on Medicaid and telehealth. And again, I think this was the first time that CMS had done that. And so was a very sort of welcome development. The last time the data snapshot was issued was January 2021, and it provided data through July 2020. And just a quick note here, CMS notes in a pretty important caveat in the snapshot, which is that the data are preliminary. And so as those data become finalized, I think it's pretty safe to assume that there might be some changes. But they are the data that we have available now. And what they tell us is that use of telehealth really increased dramatically. CMS says that the increase was about 2,800% from March through July 2020 compared to the same period in 2019. And I think that's, very, very remarkable. The use of telehealth really peaked in April, in the early months, I guess, of the public health emergency, and since then has decreased through July. And that is true for all age groups of beneficiaries, including children, working age adults, and adults over 65. It's the adults age 19 to 64, the working age adults, who had the highest use of telehealth compared to the other age groups. And CMS notes that telehealth helped to offset some, but not really all, of the decline in certain services, notably outpatient mental health services. And that was true for both children and adults. Next slide, please. All right, so I am looking forward very much to a post-COVID world, but with respect to telehealth and Medicaid, there are a lot of things that I think we will be learning from states. The first question, an obvious question, is what will states do post-COVID with their telehealth policies? Which of the flexibilities implemented during the public health emergency will they keep? What are the factors behind those decisions, and what are the data available to inform them? We're also looking forward to learning more about state approaches and considerations in a number of areas, including payment. How will states be approaching payment for telehealth in the future with respect to, for example, parity, payment for telepresenters or distance sites, and whether there are going to be any changes with payment to plans and capitation rates. Another area of great interest is network adequacy, and how can telehealth, or how will telehealth be accounted for in network adequacy standards or assessments going forward? What are the considerations? What's hard about doing this? What is easy about doing this? Another question really has to do with quality and outcomes, and how will states measure quality and outcomes for services delivered over telehealth? Does it look different than how it's done for services delivered in person? Or does it need to, or can it be the same? Preventing fraud and waste and abuse is always an important issue in Medicaid, of course, and we'll be looking to learn from states here, both in terms of approaches and what they've experienced during the public health emergency. Next slide, please. Other areas of interest include the availability and completeness of data, and this includes data on utilization, spending, and the beneficiaries who are users of telehealth. And these data points are all very important for developing an understanding of the effects of telehealth, particularly in comparison to in-person services. Another area that we will hope to learn more in or about is the effect on access to care. And is telehealth really creating access to care in areas where access has been more challenging? Is it just providing a new and important way to access services that would have otherwise been had in person? Related to the bullet on the last slide is quality and beneficiary and provider satisfaction. What have states learned during the pandemic, and how will they parlay that new knowledge into the post-COVID time? And last but not least is equity and access to telehealth. Will there be disparities in access and use of telehealth services among Medicaid beneficiaries? And what do those disparities look like? What are some approaches that states are implementing to mitigate those effects? So these are just a lot of questions and a lot of learning that I think is before us. Next slide, please. So this slide has a few resources from MACPAC. I won't go through them, but I invite all of the viewers to click on the links and take a look at those resources, and hopefully they'll be useful. Next slide, please. So that's it from me. I really appreciate the opportunity, and I welcome questions.
Thank you, Joanne. That was great. I know we've had many conversations in the past over like telehealth and in Medicaid. One of the things that you brought up, and it's actually related to a question that we got from, I think it was from Deb Levine, is the question of like telehealth during COVID. Now, what we saw in COVID was there were a lot of expansions in policy, a lot of flexibilities that were allowed, including use of other types of modalities that pre-COVID-19 we hadn't really considered underneath the umbrella of telehealth. In fact, a lot of states had a lot of prohibitions against that. And I'm thinking in particular audio-only phone, and also I think Deb's question was related to texting as well. So how is MACPAC approaching that? That's sort of more broader kind of definition and approach that was taken in COVID with telehealth than it was that before COVID happened didn't really exist for there. I mean, are you looking at telehealth in like a sort of more expansive scope, or are you still looking through it through that very specific lens that existed before the pandemic?
I think, so the March 2018 chapter, which I referenced, goes through the different kinds of modalities in telehealth. And certainly, we'll look at those. But to the extent that there were new modalities being used by states, I think that we would be very interested in learning sort of more about how they were used, in what ways were they successful, were there any barriers? So, MACPAC itself doesn't have its own definition of telehealth. We rely on the sort of industry definition, I guess.
So you also mentioned network adequacy in one of your bullet points there, and that I know states have struggled with how to really count telehealth in addressing network adequacy. So it's been sort of a very, very vague area regarding that. I mean, are there any types of suggestions for MACPAC or any hints on where they should be looking at? Because this has been really a struggle for states, and how do you adapt telehealth or how do you count telehealth when you're talking about time and distance standards?
Yeah, that's a really good question. So unfortunately, MACPAC doesn't have, we don't really have a way to do that, right? But it is an area of interest. I will note that the Medicaid managed care rule, does contemplate counting telehealth or accounting for telehealth and network adequacy, but doesn't really say much more about it. The managed care rule also provided more flexibility to states in terms of network adequacy standards, and gives states an opportunity to move away from the time and distance standards, as long as there is another quantitative standard. So we'll be hoping to learn more from states about what those standards look like, and how they are incorporating telehealth. I'm sorry to not have a really specific approach for doing that, though.
Well, related to that, and I don't actually know if you're able to answer this, but we have a question that says, does MACPAC believe that the federal government should provide more specific guidance as to the use of telehealth and Medicaid, as there seems to be in Medicare?
Yeah, that's another great question. So our commissioners have not yet contemplated or deliberated on that particular question. Um, and so, MacPac doesn't really have a position on that, but it's certainly something that that we might want to look into.
Okay. Um, and we have a question from Kelly Wolf. I'm curious what you are seeing regarding school-based Medicaid, and if you think states will be expanding those services in order to provide services to kids, especially children with special needs who might have been particularly impacted by the pandemic.
Yeah, also a really great question. So we know that there's been a real decline in services for kids in Medicaid, including on the school-based services, the therapies and things like that. I think, there have been some states that have tried to do this using telehealth during the pandemic. That's my understanding. And that's another area where we hope to be learning more. And certainly the commission is concerned about the drop off in service use by the kids.
hmm we have a question from Chris Perone. We're seeing states taking different approaches to what Medicaid telehealth coverage and payment policy will be after the pandemic, particularly with regard to coverage for telephonic telehealth provided by FQHCs. Do you think MACPAC will weigh into this issue? Does it make recommendations?
So MacPac, you know, as a general matter, does make recommendations on policy in the Medicaid space. Um, and similar to my response to the past question, we haven't MacPac hasn't really contemplated this yet or deliberated on the topic, but we do know sort of the importance of FQHCs for as an access point for Medicaid beneficiaries, and are aware of FQHCs using telehealth. So again, another area that's just ripe for work, I think.
hmm I'm going to combine a couple of questions, and I think it'll be our final question. Joanne, there's people just have questions for you, so we'll try to get them back when we have all the panels here. But I'm going to combine a couple of questions together, and that is around accessibility and inadvertent disparities among different populations. And will MacPac be examining that, sort of like communities of color or maybe low income communities that may inadvertently happen because if you expand telehealth policies, do you inadvertently leave some behind?
Yeah, so that is related to the point that I had on my slides about equity of access.
Mhm,
So MacPac is certainly um, committed, and we have been really sort of looking at all of the policies that we approach or that we address through the equity lens. And so that is certainly something that we would want to look at in any telehealth work that we do. I mean, we know that not all parts of the country have the same kind of access to broadband, and we know that not all Medicaid beneficiaries have the same kind of access to technology. And so yeah, that would be an issue that I think would certainly be on the radar for us.
Well, thank you, Joanne. That was a great presentation and great questions, everyone. So Joanne will be back when we have all of our panelists for the Q&A session at the end, but we're going to move on to our next speaker, who is Dr. Sarah Salick, who has been the Chief Medical Officer for the Arizona Healthcare Cost Containment System since June of 2014. In her current role, Dr. Salick oversees all clinical operations for AHCCCS, including quality management, medical management, dental, and pharmacy services. Specific initiatives aimed at improvement of service delivery and overall health of Arizonans include active efforts to tackle the opioid epidemic, overseeing suicide prevention efforts, improving services to children with autism spectrum disorder, and improving service delivery to children and families involved with Department of Child Safety. Dr. Sally grew up in Tucson, Arizona, and graduated from the University of Arizona College of Medicine. She completed the Child and Adolescent Psychiatric Resident Training Program at Boston Children's Hospital through Harvard Medical School. So I will now turn it over to Dr. Sally.
Great, thank you so much. Happy to be here, and I'll be reviewing the specific Arizona Medicaid perspective on telehealth coverage. And so appreciate MACPAC's kind of more global overview that Joanne had provided for all states. And I'll actually take a deeper dive in regards to what it looks like for one state, which is Arizona. Next slide, please. All right, so I'm going to start with the pre-pandemic coverage. Next slide. And as Joanne had noted, it all does boil down to how individual states as well as Medicaid programs define telehealth. And so we were fortunate in that we had a pretty active stakeholder group in Arizona related to telehealth. And so they had been pretty vocal around updating our telehealth coverage. So we were able to actually make changes to telehealth coverage prior to the pandemic, and those changes went into effect October 1st of 2019. As you can see, we define telehealth in Arizona with through telemedicine, asynchronous, remote patient monitoring, which can be done via telemedicine or asynchronous, as well as teledentistry. The important note, and you'll see in subsequent slides, is you don't see audio only telephonic services under that telehealth definition. And so through the pandemic, we obviously recognized that audio only services were going to be very important for a multitude of factors. And so I'll get into that in just a little bit, but I think we were definitely in a very positive place to have expanded our coverage prior to the pandemic, and then leverage that and be able to quickly pivot into expansion, once the pandemic hit. Next slide. All right, so these high level items that you see here in regards to broadening of place of service allowable for distant and originating sites, broadening of coverage for telemedicine, rural versus urban limitations, as well as MCO flexibility. So much of that became very pertinent during the pandemic, and Arizona had already expanded in these areas. And specifically, what we had continued to hear from stakeholders is that Medicaid needed to reimburse for services when the member was actually located at home, so originating site home. And so we made that allowable pre-pandemic. Another question that would frequently come to Arizona Medicaid was in regard to where the practitioner was located at the time of telehealth service delivery, so otherwise known as the distant site. And so we provided clarification that as long as that practitioner was registered with our Medicaid program and licensed in the state of Arizona, that they can be located out of state while they were providing that service. And from a continuity of care perspective, and we saw it, for example, in telepsychiatry, that did have a significant impact in regards to continuing to leverage telehealth in the state of Arizona. And then in addition, these three, aspects as far as broadening our coverage as we defined it pre-pandemic, I'll be covering in subsequent slides. So there were actually some misunderstanding around policy coverage in Arizona pre-pandemic around that we only covered it, for example, in rural Arizona. And so we had clarified, no, we cover telehealth for both our rural as well as urban communities. And what was unique, and Arizona's had an 1115 waiver, and we've had mandatory managed care since our inception here in Arizona, that our managed care organizations pre-pandemic had the ability to leverage telehealth where they saw that it was important to do so. And that also changed during the pandemic, which I'll cover in a subsequent slide. So if we can go to the next slide, this describes kind of some of those expansions that occurred pre-pandemic. And so in our pre-10-119 policy, we limited telemedicine coverage to 17 distinct disciplines. And starting 10-119, we removed any restrictions on disciplines. and really deferred to scope of practice as well as standard of care, which Arizona Medicaid doesn't set, but it's really through the licensing boards. And so that was a pretty significant expansion that we had implemented pre-pandemic. Next slide, please. And then same with asynchronous, we covered it in very limited circumstances pre-10.1.19, and starting on 10.1.19, we expanded it to these disciplines, as you can see here. And this was based off of subject matter expertise, consulting with Access, as well as through public comment. And we had actually added infectious disease as well as allergy immunology disciplines to store and forward after a public comment period. Next slide, please. And then for telemonitoring, which can be done via synchronous or asynchronous technologies, we limited it pre-10.1.19 to congestive heart failure. And we eliminated any diagnostic-based restrictions for 10.1.19. Next slide. All right, so going into the pandemic, if we had actually covered some codes via audio-only services pre-pandemic, but greatly expanded audio-only coverage for some of the reasons that Joanne had mentioned. And part of that is from an equity standpoint, as well as access to care, including for our rural communities in Arizona, in particular around those communities that have issues with broadband access. And the primary mode as far as us creating this temporary telephonic audio-only code set was our stakeholders. And so we got many requests, and for the vast majority of requests, we added it because we knew we were unprecedented times with a pandemic, and we wanted to continue to promote access to care through telehealth, including audio only, as well as limit the spread of COVID-19. We also expanded the codes that were on our specific telehealth code set and added over 150 CPT and HCPCS codes to that code set. And unlike the pre-pandemic time period, we actually had requirements for our managed care organizations to reimburse at the same rate for services that are provided in person versus those via telehealth modalities, including audio only. We also required them to cover all contracted services via telehealth modalities. And so those were, two very specific policy changes that we made during the pandemic. Next slide. All right, and so I'm going to go into a few data slides. And so this first data slide is looking at from 10/1/19 through June of 2020. So just through the first quarter of the pandemic. The rate of utilization by mode of service delivery as a rate per 100,000 members. The top line is all service delivery as a rate per 100,000 members. The blue line is in-person only, meaning the individual only received in-person care, whereas the yellow line was one or more services were provided to members via telehealth modalities, including audio only. And so as you can see, and as Joanne also mentioned, we did see a significant dip in-person service delivery. That's designated by that blue line. And thankfully, we did have an uptick as a rate per 100,000. We went from just under 5,000 back in to see that increase in March. And then again, as noted from a national perspective, saw that peak in April around a rate per 100,000 and then some trickling back down. But the other thing I wanted to note, and again, this has been noted on a national level for Medicaid, is just the overall service utilization as identified by that green top line still is not back to that pre-pandemic level despite telehealth coverage expansion. So overall service delivery, is down despite the significant growth in telehealth. Next slide. All right, so this next slide actually looks at it from a claim encounter perspective, and this is the total number of claims, and looking from basically 10/1/19 through 10/31/20. And as you can see, we've actually separated out telehealth from telephonic, and the telephonic being the audio only. You can see that significant increase, and more claims are coming in for audio only services in Arizona in comparison to telehealth as defined by that interactive audio video, asynchronous, as well as teledentistry. And so that kind of gives you a little bit of an understanding, again, kind of peaking in April, leveling out. But what's interesting on this graphic is that you start to see telehealth start coming back up, after the April pandemic. And for those, for those not aware, in Arizona, we did have a peak in July related to our pandemic. And so not too surprising on that front. Next slide. All right, and then this one looks at just a snapshot for a month and splits it out from in-person behavioral and physical health services from telehealth. So the vast majority of our services are still being done, in person from a claims encounters count perspective as of September 2020. But as you can see, the telehealth slices of the pie, are larger for behavioral health, which has historically been the case in Arizona, than for physical health service delivery. And the telehealth does incorporate, the telephonic services on this slide. Next slide, please. Last but not least, although you saw that for September of 2020, you saw that smaller piece of the pie being telehealth for physical health services, I did want to note in controlling for a rate per 10,000 by county for physical health services only being delivered via audio visual as well as store and forward, we still saw a significant increase as identified through this county-based analysis that we had conducted, with the blue line being the pre-pandemic numbers and the yellow being the post, or during, I should say, during pandemic numbers. We all want it to be post-pandemic, but we're still in it. Hopefully near future is coming up. All right, so speaking of which, we'll transition, which is to the next slide, which is our planning for the post-pandemic period. And so we have extended our current flexibilities, including paid parity, as well as coverage for contracted services through our managed care organizations through September 30th of this year, with the plans to actually finalize our policy decisions by July 1st of this year. Next slide. And then in order to inform our decisions for that post-pandemic period, again, making the assumption that hopefully by 10/1 of 21 will be post-pandemic. Obviously, if we're not, we'll reevaluate, that coverage. But we want to make sure that, we've crosswalked the actual CMS core set HEDIS measures, the NCQA specifications for allowable via telehealth with our allowances on our code set to make sure that it's in line with that. So we're able to count the services towards those performance measures. As Joanne also noted, we're continuing to do our financial analysis, including offsets of non-emergency medical transportation costs when members receive services from home. We also are in the process of implementing our CAP survey for our major lines of business here in Arizona, as outlined on this slide. And, through this collaboration, we were able to identify specific telehealth questions that Oregon had adopted, since NCQA CAP survey did not have specific supplemental questions for telehealth. So we actually adopted Oregon's CAP specific telehealth questions. So hopefully we can do some cross-state analysis. And with that, I think that is my last slide. Oh, this is my last slide, as far as this is a nice summary slide, including kind of the detail, including the use of modifiers. I did want to note at the start of the pandemic, my office considered just making it super simple and not worrying about modifiers, but we had determined to stay the course. And I have to say, from a data perspective, I'm so glad that we did, because now we have the claim-based detail to identify the different modalities of telehealth. And so with that, that's my last slide.
Thank you, Dr. Salek, and thank you also for noting the collaboration that you did with Oregon. Was there when you guys connected on that particular question there. So we've got a couple of questions for you. So from Lindsay Baywall, and I apologize if I'm mangling your name. Did Arizona have any state laws that restricted the types of providers, types of telemedicine that could be utilized. We are experiencing some issues in Indiana as our providers are limited by the scope of their licensure, and we are restricted by state law on what our definition of telehealth can include as far as different modalities.
Yeah, that's a great question, and we absolutely encountered a similar experience here in Arizona because we developed our code sets based on scope of practice. So, for example, our medical coding manager, cross-validated with the different licensing boards to make sure that we were in line with that. The one licensing board that comes to mind that says, you know what, telehealth modalities, including interactive audio video, this was pre-pandemic, was physical therapy board. But was interesting in Arizona, our governor at the start of the pandemic issued an executive order that required payers to basically pay, all licensed practitioners for services delivered via telehealth. So that executive order basically superseded the specific boards limitations on telehealth delivery. So that's how we got at it during the pandemic, and it'll be interesting to see if that actually stays in the licensing board. For example, using physical therapy as an example, if they decide, given the experience during the pandemic, that in fact, these physical therapy can be done via, interactive audio video, for example.
And I think that's also a good thing to point out for some people who aren't in the Medicaid program, working in the Medicaid program. It's not entirely up to the Medicaid program in some of these decisions. There are other factors that are involved, such as laws and other agencies that might impact how far they can go with policy as well. You touched upon the distance site provider in Arizona being able to not actually be within the borders of Arizona, but we have a question from Joel Torres asking about the patient. Does the patient need to be within the borders of Arizona at the time of the telehealth interaction? Because we saw that a lot with the pandemic. People sometimes got stuck in other states.
Right. Yeah. And I think there was a lot of flexibility during the pandemic. I think, in regard to at the end of the day, we want services, whether that be from the state that they were actually in at the time versus via telehealth. So we did get a lot of those questions. I think that unfortunately is more complicated in regards to when a member is located out of state. It's actually been an easier question to answer from a practitioner perspective, as long as they're Arizona licensed. But it becomes a little bit more tricky when one of our members is out of state. But I would just note that we've been flexible during this COVID period for the reasons that were mentioned.
Mm-hmm. You had a slide that showed the difference in the utilization of like telephone and telehealth. So there's a question here. Do you have the same coverage and payment for both telephone and video, or are they paid at different rates?
Yeah, so great question. So we differentiate based on our coding and use of modifiers as well as place of service, what codes are covered via audio only versus telemedicine. So we do have certain codes, for example, that are only available via telemedicine and not on audio only. So that's the kind of the answer to the first question. And then we have codes that have both, for example. The second part of the question is we have pay parity right now for both audio only as well as interactive audio video as well as in person. So there is no differentiated rate amongst those modalities of care. And where I've seen the most interest both locally and nationally is around that audio only. And should there be pay parity there? Right now in Arizona, there is a current bill that is impacting commercial and private plans. It's not pertinent to Medicaid in regards to, it doesn't directly impact us, but it indirectly impacts us, which basically does call for pay parity across both audio only as well as audio visual in comparison to in person. And I think that will indirectly impact Medicaid policy in Arizona.
Mm-hmm. Yeah, and follow up to that, and I don't know if you can actually say anything at this time, but there is a question of like, what is the plan for Arizona Medicaid regarding telephone coverage? Will that be continued or will it be scaled back? I don't know if you can speak to that at this point.
Yeah. I can, yeah, I'm happy to speak to it. I mean, all of the codes that we've added to interactive audio video, we're planning on maintaining all of those. I think where the major policy decisions live is around the audio only coverage, because it's really looking at, you know, quality of care versus access to care, right? Because of some of those broadband issues. And so until we address those broadband coverage issues, we still need to be flexible with our audio only coverage. That's my perspective. And so the other thing that's going to be helpful, anecdotally, we're hearing that individuals really like the service delivery via telehealth, but having that caps on a more global level is really going to help us understand member satisfaction with telehealth covered services. So we'll see what the results of that show. And then lastly, we'll see what happens with the bill in regards to pay parity for on the commercial side, because I think, again, there'll be an indirect impact to us to follow suit in regard to that pay coverage. And in having telehealth forums here with providers, I think there's a level of understanding that we may need to look at different models of reimbursement for audio-only services versus the interactive audio video, keeping in mind we need to address the broadband issues.
Mm-hmm. So we only have time for one more question, but Dr. Salick will be back for our full panelist Q&A session, and that's around network adequacy. So what has Arizona Medicaid been thinking about telehealth and network adequacy?
Yeah, we're absolutely, you know, entering into that equation for our network adequacy for our health plans for 10/1/21 and beyond. And we're working with our ECRO to develop the most appropriate strategy, including, for example, is there, you know, a certain threshold if our managed care organizations are able to demonstrate that they have telehealth coverage in particular fields, you know, primary care services, for example, that does that count toward their overall network adequacy, and how would we apply that? So I think similar to what Joanne had noted, that I don't think my experience is the ECROs haven't fully figured it out and are still researching the best way to apply telehealth, understanding that a lot of times it's time and distance. Like we use time and distance standards in Arizona Medicaid, and that looks a lot different for telehealth, given some of the originating distance sites that we discussed.
Okay. Well, thank you, Dr. Salick. As I said, she will be back for our panelist Q&A, but we're going to now shift over to Colorado and Dr. Tracy Johnson. So Dr. Johnson brings more than 20 years of experience in health policy and program development, research, and evaluation. She currently serves as the State of Colorado Medicaid Director in the Department of Healthcare Policy and Financing. Previously, she was with the Denver Health and Hospital Authority, where she served as DHHA's Director of Healthcare Reform Initiatives. She led Denver Health's implementation of federal healthcare reform, specifically in the areas of delivery system and payment reform. Prior to that, she served as principal of her own health policy consulting firm and in state government. She holds a PhD in health policy and management from the Johns Hopkins Bloomberg School of Public Health and an MA in biomedical ethics from the University of Virginia. And I'll turn now over to Tracy.
Hi, thank you. Really glad to be here. Really enjoying participating in this panel. Learned a lot from the previous presentation, so thank you. Next slide, please. So like the previous presenter in Arizona, Dr. Salick, I'm going to talk to you a little bit about what does this look like in a specific state, Colorado. And our policy frame around telemedicine is that we're hoping that a comprehensive telemedicine policy can help us improve access to high quality services, promote health equity, integrate with the medical home and neighborhood, prod innovation, and we think to do that, we're going to have aligned payment policy. Those things will have to kind of work in tandem and ensure value for the taxpayer dollar. So that's sort of the policy goals of our policy. Next slide. So just to kind of give you some context, like Arizona, we had a pre-existing telemedicine policy that was really helpful when we had to turn on a dime in the middle of March. We were one of the states that the pandemic hit rather early. And on March 20th, we had emergency rules that expanded the modes and the providers that could provide telemedicine. If you could click through, there's some animation here. You might have to click several times. Like Arizona, we added the telephone only modality and live chat. We did not We did not authorize asynchronous modalities, so that would be a difference between us and Arizona. We did allow different kinds of providers that previously were not allowed to bill directly: federally qualified health centers, rural health clinics, Indian Health Service, and community mental health centers. For physical health services, we are a fee-for-service state, and that's relevant to some things. The other thing that we did somewhat unusually compared to other states is we did allow therapists to bill, and that impacts some of the data I'll show you. So physical therapy, occupational therapy, home health, hospice, pediatric behavioral health providers, all of those were not previously allowed to bill on the fee schedule, but were allowed to due to these emergency rules. Next slide. And like Arizona, we had payment parity. The one thing that was on the previous slide, but in case you didn't note it, our emergency policies were passed in March and they were made permanent in June. Our legislative session got delayed due to the pandemic, and some of our emergency policies were set to expire in July. And since we were really sort of just barely coming out of that first COVID wave, there was some anxiety that these flexibilities would disappear. And so nearly all of our emergency policies were made permanent in statute, with the commitment that we would sort of evolve our policy in an ongoing way, but have a basis in statute. And so that has some pertinence to how we're approaching. We've done a major evaluation, internal evaluation. We've commissioned a subsequent evaluation with the University of Colorado, digging into some areas. We did some literature review. We, as I said, commissioned research. We talked to lots of stakeholders. We did a member survey that was a convenience sample. We've also added questions to a population-based survey that's being fielded right now with data expected in the fall. We looked a lot at utilization. We also commissioned some budget modeling stuff that helped us try to think about what would it look like post-pandemic with telemedicine, and did lots and lots, we participated in lots and lots of collaboratives. I'm going to get, our evaluation will be made public and can be shared with this group. I think it'll be out probably maybe next month, I'm thinking, and happy to share, like I said. Next slide. I'll give you a little bit of teaser in some of these slides of the kinds of data we'll have in this report. So on the physical health side, we're a fee-for-service state, as I said. So the left shows sort of the telemedicine dramatic uptick in March. And like Arizona, it's leveled off a little bit subsequently with a more recent sort of uptick. And if I didn't have it on this particular slide, but in the more recent data that I have in-house, it is continued to uptick because we've had sort of a second wave in Colorado, like many states have in the fall. Our behavioral health services are capitated, so we did get data from our managed care entities, and they show a similar pattern where telemedicine was permissible and was used prior to the pandemic, but just ticked up dramatically in March and April, and has tapered off a little bit, but not as dramatically, that taper off aspect as compared to physical health services. So the telemedicine modality in behavioral health continues to be quite popular. Next slide. In terms of who's using telemedicine, we actually have a lot of use of telemedicine by children. Therapies there being a key driver. Early intervention in our state is 100% virtual, and much of it can be billed to Medicaid, so that's partially a driver. Adults, some of the top diagnoses are opioid dependence. There are certain behavioral health services that are carved out of our managed care contract, and there was a lot of take up of those kinds of services, fairly immediately in the data: depression, anxiety, and then chronic disease management. Adults with disabilities, for that population in particular, the telemedicine service that's most often used relates to chronic disease management, which isn't surprising given the complexity of the population. Next slide. Urban uptake is higher than rural, and both for medical and behavioral health. And we were a little bit surprised by this because we were hoping that the audio-only modality would help with the fact that broadband is an issue in rural areas. And it seemed to help but not completely address some of those rural challenges. What we heard from our stakeholders was, you know, some of the urban provider systems are just larger and they have more administrative staff. And, you know, this policy came out very rapidly from Medicare, Medicaid, and commercial, and didn't necessarily agree. And so rural providers kind of reported to us when we asked, you know, why the take up was lower, that, you know, people were just confused about what was allowed and they weren't sure if it would be permanent. And so we did a lot of webinars to try to make sure our rural providers knew that, you know, it was now permanently in statute and it was available. I will tell you that we still see that urban-rural divide in our data. And then I'll talk about ED trends in the next slide. So go ahead to move on. I talked about some of the health equity things already, the rural-urban divide, ability to access and navigate technology. We saw that a lot in some of our older populations, although with appropriate supports, they were surprisingly willing to do this. Language is a barrier, cultural competency, you know, people with disabilities, some disabilities do not lend themselves to telemedicine modalities, the nature of the disability itself. And then some populations, homelessness was sort of you know, they're a challenge reaching that population typically. There were some interesting telemedicine opportunities with this population during COVID, particularly when people were housed in hotels. Sometimes they actually had better access to telephones than they had other times. But these are all populations that you need to think about differently for telemedicine. And we're going to do a subsequent analysis that does a deep dive looking at some of these subpopulations. Next slide. We did a convenience sample of members. This is a group of people that advise us regularly, and it's tilted toward people who have disabilities, so it is in no way a random sample, but it's still informative. We asked people, you know, if they accessed audiovisual, you know, what modality did they use? Was it FaceTime or Zoom or through a, you know, a provider tool? Because some of those modalities may change depending on what's decided with HIPAA federally. 84%, 84.3% were very satisfied with their services through telemedicine. And when they asked what would have happened if telemedicine weren't available, 69.1% said they would have delayed care and 9.6% said they would have gone to the ED. We're asking similar questions, as I said, in a population-based survey, so we're very interested to get those results back in a more statistically valid way. Next slide. Here's some of the data, similar to the data Arizona presented. So I know this is probably small, but the colors are pretty informative. So the blue bars represent in-person care. And there's like that dotted line around the middle of the graph, which is pretty much pre-pandemic. And even though telemedicine was available as a modality, actually not for these particular service providers, you don't see any orange pre-pandemic, because for these particular providers, they weren't allowed to bill separately for it. And so then there's this dramatic uptake in March. And for some providers, they get up, you know, the total height of the bar gets to be pretty close to what it was pre-pandemic. So you can see that telemedicine really did help them offset the in-person visit drop. But if you look at our rural health clinics, so the first two lines are federally qualified health centers divided into rural and urban. And you can see that greater uptick in urban providers, but still pretty dramatic uptick in federally qualified health centers. They're large institutions for the most part and have some of that administrative resource that can help figure out new policies. Our rural health clinics really have had low take up despite efforts to outreach and train. In Indian Health Services, there is orange on that graph. It's just so small you can't see it. So this does sort of point to some health equity issues, which again, we want to dig into and understand better. Next slide. There are budget implications of this dramatic telemedicine uptick. we went from, nearly no spend on telemedicine to 210 million spend in the current fiscal year 2021 that we're in. That's projection, and then maybe up to 253 next year in a budget year where revenues are declining because of the pandemic. And so right now, you could see hopefully visually from the previous graphs that telemedicine is offsetting in-person utilization, but we're sort of interested in knowing, well, what happens when in-person utilization returns to normal? Will telemedicine still be this kind of offsetting thing, or will it be additive? Next slide. So we've tried to get at that a number of ways. It's not displayed, but we've sort of looked at whether telemedicine visits is increasing the visits per person. And there is some evidence of that, particularly in people with chronic disease. So that would sort of get at that question of whether it's additive or whether it's sort of substituting. The other thing we've been looking at is a cost modeling exercise to look at, from a provider perspective, what has telemedicine done? What has it done to their costs? What has it done to their revenue? And, do they have any sort of financial benefit? Because a lot of our rate setting at the Medicaid agency is really based on what does it cost a provider to provide a visit. And one of the things that we found in this cost modeling exercise is that there's actually a bigger gain in productivity than there is in costs. A lot of people have sort of been looking at, well, is there some cost efficiency in how much it costs to provide a telemedicine visit? And there is some advantage there according to our modeling, but the big advantage is, people are more likely to show up for their telemedicine visits than they are for, an in-person visit. And so providers are actually able to do more visits per day as a result of that efficiency. And so it's the sort of more visits per day that allows the cost per visit to go down. And so we're sort of thinking that through in terms of, what should we be paying for a telemedicine visit going forward, after the pandemic. Next slide. The other thing we're thinking about are offsets. In the Medicaid program, but also in commercial populations, we have a large population that goes to the emergency room for things that could be handled in primary care, such as, kids for colds and upper respiratory infections. And, pre-pandemic, there was a level of ED use, just shown here. And then post-pandemic, a lot of people are not going into the ED. Not all of that avoided ED is good. People are avoiding the ED for things they should be going to the ED, which is why we tried to narrow this to things where avoidance is probably desirable. And we saw that not only did ED visits go down, but there appears to be a substitution for telemedicine visits. And so we're trying to think about, well, could we craft policy to encourage this direction again, post-pandemic? Next slide. So in terms of next steps, we're really looking at, even though we made all of our emergency policies permanent, we do know that we need to refine over time. And given that the pandemic is going on for an extended period of time and the public health emergency has been extended, we'll probably take the next year or two to really figure out what our permanent policy should look like. We want to make sure our medical homes remain integrity. And so we're trying to think about, how does telemedicine augment the medical home and not compete with it? And what do we need to do from a policy perspective to ensure that happens? We're interested in building out e-consults, like it sounds like Arizona already has, and continuing to monitor utilization and think through, how do we pay? Not just like, do we pay at parity or not, but like, is fee for service, which is, the model we're in our state, the right model to really prod innovation? Or do we need to think about value-based models or take advantage of our managed care entities on the behavioral health side where that makes sense? That might be my last slide. Next slide. Oh, and just here are some resources. Our evaluation that I just showed you some snapshot slides for will be posted on these similar websites, and some of the utilization I showed you is also posted. We're required by legislation to do that every couple of months, so it's actually relatively up to date. If you want to give us any feedback, we have a feedback form, and all of our billing policies are displayed here as well. Thank you. Appreciate.
Thank you, Dr. Johnson. We have a couple of questions here for you. So one of them was just a clarification question. You mentioned that a lot of children were receiving services via telehealth, and somebody was wondering, is there an age limit as to like when they stop receiving those services?
No, there's no age limit. I just was, we were looking at national data and I think Arizona, or maybe one of the previous two presenters, talked about how adults use telemedicine more than kids, and that's not what we were seeing in our data. And when we dug into it, we saw the reason for high utilization among kids was really driven by the therapies, and in particular, therapies to young children ages 0 to 3, which is early intervention. And so not all states expanded therapies like at all. And so we thought, well, maybe that's why Colorado looks a little different than the national trends,
Okay.
both on the children and on the therapy use.
A clarification question. Somebody thought they may have missed this, but does Colorado offer remote patient monitoring reimbursement?
In a limited sense. That wasn't a big part of our policy change, certainly. And you know, there are examples of that, but it wasn't the focus of our COVID response. We do actually have some legislation going forward this session to expand remote patient monitoring for people with disabilities in some key areas, but that's sort of a newer thing, and nothing I really showed you today addresses that topic.
Okay. I'm going to be mindful of time, so I'm just going to take one more question for you, Dr. Johnson, but she will be back for our panelist Q&A. How aligned are the Medicaid MCOs with your state programs?
So if you're talking about the Medicaid, so that's a complicated question. So there are Medicaid MCOs that provide physical health care, and then there are managed care entities that do behavioral health. So I'm not really sure which part they were interested in addressing.
They did not clarify, but maybe if they could clarify for that, we can maybe take that question up in the panelist Q&A. So we're going to move on to our next speaker, who is, thank you, Dr. Johnson. Our next speaker is Lori Coiner, who is the medical director that oversees Oregon's Medicaid program, covering nearly 1 million Oregonians through a coordinated care system led by 15 coordinated care organizations. She returned to the role in February 2019 after a year consulting with Health Management Associates as the managing principal. During her 2015 to 2017 tenure as Oregon's Medicaid director, she played a pivotal role in securing federal renewal of Oregon's Medicaid 1115 waiver that includes innovative strategies to incent investment in social determinants of health, value-based payment methods, and continues Oregon's health system transformation that includes Oregon's Quality Incentive Program. Lori previously served as Director of Health Analytics at Oregon Health Authority, where she led the development of the CCO Quality Metrics and Incentive Payment Program from the ground up, and a hospital transformation performance program that paid 28 Oregon hospitals for performance on quality metrics. Prior to joining OHA, she served as the Director of Measurement and Reporting at the Oregon Healthcare Quality Corporation. She received her MA in Statistics from the University of New Mexico and a BS in Chemistry and Math from the University of Puget Sound. So I will now turn it over to Lori.
Good morning, everyone. I'm here to report on telehealth progress in Oregon. And what we've seen, I guess I'll just start off to say, is very similar in many ways to Colorado and Arizona. And I think I have a few interesting twists, but for the most part, it's going to be fairly consistent with what you've seen prior. So can you advance this slide, please? I'm going to start by giving just an overview of the Oregon Health Plan, kind of where, just to give you a quick snapshot of the way that we have our coordinated care organizations organized in our state and the focus of the Medicaid. Next slide, please. So Oregon's vision around its Medicaid program, and what we call the Oregon Health Plan is a patient-centered system that treats the whole person, and it focuses on health and not just healthcare. So we have a very strong focus on health equity, on prevention and outcomes for our coordinated care organizations. Next slide. The coordinated care organizations were created through an 1115 waiver in 2012, and the goal was really to improve care delivery in Oregon. They are local organizations for the most part. We now have 16 across the state. And in that program, they have a very strong focus on patient-centered primary care homes. They cover the full benefit, which includes oral healthcare, behavioral healthcare, and physical healthcare. And they do all this with a focus on maintaining sustainable spending and measure performance. We cover, I guess I'll just say right here, we cover about 1 in 4 Oregonians on Medicaid in our program. Next slide, please. 1 in 4 Oregonians equals about 1 million. We're up to 1.2 million through COVID, and 41% of the Medicaid members and members on the Oregon Health Plan are children. That the face of Medicaid in our state really changed with expansion, and so now we have about 60% adults. The Oregon Health Plan includes Medicaid, CHIP, kids. We also have a program called Cover All Kids, which covers kids regardless of their immigration status. And similarly, another general fund only program on reproductive health coverage. Next slide. I'm going to talk a little bit about telehealth in Oregon and what we've seen. Like Colorado, we were an early state in terms of COVID infections. Our team jumped very quickly into implementing telehealth and working really hard to get information out to providers and members on how to use telemedicine as a modality. This slide shows payment across the 2020, well, at least up to October. And the fee-for-service program is about, runs 10 to 12% of our total program, which is why the slide is, or why the total spend is so much lower. We saw a 60% uptick in telemedicine across the system. You'll see in Oregon, prior to the pandemic, we had very little reimbursement for telemedicine. It spiked, just one packet, it spiked in April. And I think unlike maybe what was shown in Colorado and Arizona, we've maintained a fairly, it went down and then we were maintaining a very kind of stable level of the use of telemedicine across Medicaid. Next slide. This expansion was supported by rapid policy change. We had policies and new flexibilities in the Oregon Health Plan that include increasing coverage, the types of telemedicine that could be covered. So that include audio only, it include allowing platforms that weren't fully secure. It included allowing providers and members both to receive their telemedicine services at home or deliver them at home. Through the governor's office, there were also voluntary agreements with major commercial insurers, and both the Oregon Health Plan and the commercial insurers agreed on some levels of payment parity across that time. And as some of the other states mentioned, our state licensing boards eased regulation on out-of-state providers. So there has been some out-of-state providers, particularly on our eastern borders, providing telemedicine services. Next slide. One thing that we've noticed in Oregon is that the behavioral health visits are the most common. And we are hearing and seeing that behavioral health visits are also part of what's keeping that telemedicine utilization stable. This slide shows the primary diagnosis of telemedicine visits from January through December, though the last 3 months with claims lag are going to be a little, low. And what we see is there were, nearly 200,000 visits for opioid dependence, another 170 for PTSD, and on the behavioral health side. And then when you look on the physical health side, you'll see that there are many fewer visits. And so those, the most common was for hypertension, and the second most is around contact with and exposure to viral diseases. We have heard just anecdotally that many members like having behavioral health through telemedicine. I know at least one coordinated care organization also is allowing behavioral health visits to be split. So they pay on one visit, but the members may want to have 30 minutes and then a break and then another 30 minutes. And so some of the coordinated care organizations have been exploring with kind of creative ways to make a telemedicine visit more workable for our members. Next slide. I know at the beginning when we were talking about the look forward on telemedicine. In Oregon, we've gone ahead and moved forward on developing some permanent policy. And so we developed permanent rules for our Medicaid program in the fall of 2020. Those rules went into effect January 2021. And so some of those I will describe here, and they're in that box. So the first is to allow providers to continue to deliver telemedicine services from their home, and patients to receive telemedicine services in their homes, even when they don't have the full secure platforms. The other is to allow new patients to receive a telemedicine visit. Prior to COVID, only existing or established patients could receive a telemedicine visit. And the final is payment parity. We will continue in Medicaid to use the same payment rates for telehealth visits as with in-person. I want to make a comment about that because we are going to be watching the audio only services closely. So for now, in the permanent rule, we are paying parity on audio, so telephone only services. We have had discussions with community groups, a stakeholder advisory committee, and comments from providers where there's some concern and there's tension on that audio only service type of visit. We heard from some providers that without having eyes on the patient, it can be difficult to deliver appropriate care, even in the behavioral health arena. On the other hand, we hear from stakeholders that they don't have access to video platforms and good broadband, and so it's really important for them to receive telephone only visits. What we will be doing is watching utilization and continuing with stakeholder engagement around this topic, and may modify the rule later. Next, and then I guess the only other thing I'll say is that the Oregon Health Plan uses a prioritized list of services, though that's our covered benefit, and we did make permanent changes to the codes that allow telemedicine in our prioritized list. So the future of telemedicine, we are moving forward with kind of these three big areas of focus. One is to center on equity. Our agency's 10-year strategic plan is to eliminate health inequities in 10 years. And so we are going to continue to focus on some of the equity issues that Tracy raised in her earlier presentation. Also continue to look at data on what is working and what isn't, and then continue to coordinate and align across payers, including commercial. Next slide. One of the areas that we heard where there was concern is access to interpreters. And so here's one place where we're centering on equity. We know that some members had a hard time getting an interpreter for their telehealth visit. What we did to solve that problem was to require that providers reimburse interpreters at the same rate as if the person is, you know, in an office visit. And then also we are sending a message about patient choice, because we know that some non-English speakers have a really hard time with a third-party interpreter on a telemedicine visit. And so that we want to ensure that patients have a choice of an in-person versus telemedicine visit. We also created a new incentive metric focused on meaningful language access for the CCOs, and so they're paid on that. Next slide. This is a map of our broadband coverage. I'll say really quickly that Eastern Oregon, the part on the right, is frontier, and those red patches are places where there is no broadband, though people live there. Blue is the darkest blue is the best broadband coverage. So all of Eastern Oregon is at best, you know, underserved in broadband. And this is a real concern because that's the area where people drive hundreds of miles for a doctor's appointment. Our governor in her current budget package does add $118 million to improve broadband. And so we'll be tracking this as well. Next slide. In order to understand what is working and what isn't, we'll continue to closely monitor the data we have. We're going to continue to talk to community partners and stakeholders, particularly those that come from BIPOC communities and some of these rural communities with difficult access. We added some new questions on our CAP survey and our Oregon Health Insurance survey that goes to providers, and looking at workforce as well. And then we're involved in a multi-state collaborative with California, Colorado, Nevada, and Washington, where we're sharing and evaluating aspects of telehealth across multi-states. Next slide. The other piece that is important is our aligning across payers, aligning with our public health programs to move policy forward around telemedicine that's consistent, or at least that we understand the differences between Medicaid, commercial, or public insurance, and some other coordination across these agencies. Next slide. Here are some resources. The first are our telehealth rules that we had approved and started in January, and also our prioritized list. And we created a Medicaid provider guide that includes information about telemedicine services. So thank you, and I'm ready for questions.
Thank you, Lori. That was great. So our first question, it was really interesting when you showed the data that unlike the other two states, Arizona and Colorado, you didn't have as drastic of a dip in telehealth utilization, like when kind of the pandemic kind of eased or when things started opening up. Why do you think that was? At first I was going to say, oh, do you have better broadband? And then you showed the broadband maps. Like, it's probably not that. So what do you think is the reasoning for that?
I think it's, I don't know for certain, but I do believe that it's related to behavioral health. We know that the behavioral health system has dramatically expanded their use of telemedicine, and we expanded the number of codes that could be used and accessed by providers. And so, and that's where our biggest uptick has been. So I assume that that's why it's continuing.
Okay. How are you working with other agencies, regulators that have policies that might limit the reach of your new telemedicine policies? For example, policies governing how, by whom, to whom providers can provide controlled substances for treatments. That comes from Alexis Horan.
So, you know, one of the things that we created about in the summer is we have a cross-agency telemedicine group that meets. It includes also some community partners and then individuals across our agency to talk about areas that affect kind of what is happening. And that's been quite effective because Medicaid was moving forward with a lot of telemedicine policy. And then that was affecting other areas of our agency. And so we have regular meetings, to walk through policy issues. And, it includes the people that manage our behavioral health services, for example, public health, and so forth.
All right, I'm going to invite all of our panelists back here. We've got a couple of minutes for like all panelist questions, and I will kick us off. So Joanne, you had mentioned that MACPAC would be interested in outcomes data, and I was wondering if any of the Medicaid programs is tracking that on your end on outcomes and related to like telehealth and telehealth utilization.
This is Lori. In terms of outcomes, what we are looking at is, like I said, we developed an incentive measure on interpreter services, and so it's not directly related to a telemedicine outcome, except that it's related to the use of interpreter services when they're needed, which is important because we had heard quite a few issues for members, particularly in BIPOC communities and immigrant communities where language access was very difficult, and they had a difficult time, having an in-person visit. So we will be looking at that. CCOs will be paid on the basis of their performance on that metric.
Yeah, I would say that we're sort of upstream of a true outcome measure, partly because it takes a little while for a service to be in place for a while to measure outcomes. So the closest we get to that is some of that data I was showing you about, are people getting their needs met in sort of more evidence-based ways that are closer to primary care, so is the service model closer to what you want, so people are able to get after hours guidance, ideally connected to their medical home in some way about a child who has an upper respiratory condition. I think that's sort of approaching what the literature would say is a better way to treat that kind of condition. And, we're looking at, as I said, our visits per person increasing, and we saw that happening for chronic care. And, it's been often mentioned that having more intensity around people who have chronic disease is something that's desirable. And so, we're sort of looking at, well, is there an opportunity there to treat chronic disease better via telemedicine? And, as a fee-for-service state, we're also thinking about, okay, that intensity could be costly. So do we need to do some sort of value-based model to sort of, encourage what might be sort of a better clinical practice, but quickly could become unaffordable if we don't, get the payment model aligned. So we're looking at those kind of things. And then eventually we'd like to see like, okay, and then are the diabetes outcomes or, the asthma outcomes improved, but we're just not quite there yet, but we're trying to lay the groundwork so we could do that analysis, if that makes sense.
Mm-hmm. You're getting a lot of head nodding from your fellow panelists there too. So I think you probably summarized that very well. We've got a question like, could each presenter address the use of telemedicine and telehealth as integrated into school-based health centers?
I can start. We haven't integrated it yet. I mean, with schools being out, we don't have our students haven't returned, and so I'm not sure what that's going to look like yet. So I don't have much to say. Sorry.
In our state, it sort of depends on how the school-based health centers are organized. As you heard in my introduction, I used to work at Denver Health, and Denver Health runs a lot of the school-based health centers in the metro area of Denver, and they have made extensive use of telemedicine, and so some of the school-based health centers have benefited from that, but it really depends. And the other thing that was a factor in Colorado is we did not until very recently allow well child visits to happen via telemedicine. That was a recent policy change, and that really expanded the opportunity for school-based health centers to provide a service that they were not prior to November allowed to provide. So, so again, it sort of depends a little bit on which school-based health center you're talking about in our state, and also, reflects our policy decision timeline.
Mhm. Dr. Salick, do you want to speak from Arizona's viewpoint, or?
Sure. Yeah. And I think it just depends on each local district and how they approach healthcare services within the education setting. What I will add is that we've done a huge push for behavioral health services in schools, and it's partnering with our public behavioral health service providers. And so some are co-located, but during the pandemic, our public behavioral health system is continuing to provide services to kids in schools through telehealth modalities. And so I think it's a matter of like the school-based claiming versus just our public, Medicaid system, and that continues to be very active during this time. School-based claiming is still occurring as well, including where telehealth where appropriate, but really where we're seeing the vast utilization is through our public behavioral health system.
And Joanne, is that an area, school-based telehealth, that MACPAC is particularly interested in?
Yeah, so we have done some work looking at school-based services, so that those would be the services for children under their IEPs or IFSPs. So some of the therapies that might be occurring through schools. But in addition, there's school-based health centers, right, who are like really important access points for kids, in the days that they're actually in school. So yeah, I mean, I think to the extent that they can be used to improve access for things such as like behavioral health, which is really important for especially adolescents, I think that could be an area of interest for commissioners.
Okay, well, I want to thank all of our panelists. I know we have a lot more questions. This just tells you the quality of the speakers that we had today, that people had so many questions. So thank you, Joanne G., Lori Coiner, Dr. Tracy Johnson, and Dr. Sarah Salick for your wonderful presentations. Again, this is being recorded. So if you missed any part of this, or if you have a friend who can attend, they will be able to access the recording and the PowerPoints about 48 hours afterwards. It will be available on CCHP's website and also on our YouTube channel. Next slide, please. Again, we are doing a spring series. So if you have a Medicaid program that you think has some innovative telehealth policies that are going on there, or you're thinking of doing some innovative telehealth policies, you want to share that with your fellow Medicaid programs, please contact CCHP. Our spring series will take place in May of this year. And once again, thank you to our terrific speakers, and thank you to HRSA for helping fund this webinar series. Thank you also from me to my staff who helped put this together, and thank you everyone for attending. I hope you enjoyed this. You will receive an evaluation sheet regarding this webinar. It would really help us out if you fill that out and return it to us. So everyone, I hope you have a great day. Thank you once again.